Chronic osteomyelitis principles kind of flew through a little bit. And this is important that you recognize. Bone stability does not necessarily mean fixation. There are some osteomyelitises that you're going to treat and debride that the bone already is stable and you're not going to have to do anything. There are others that you may gain stability on a temporary basis with something like an external fixator. Coverage you should at least understand. You may well elect not to provide it yourself. It's perfectly fine to have a plastic surgeon do your extremity flaps, but in general you guys will understand the extremity better than they do, and at least on an intellectual basis you may well find that you're very helpful in determining coverage types for some of your patients. Subacute osteomyelitis is a very common question. It's one that they like, also called Brody's abscess. Patients present with pain. They have no systemic signs or symptoms. Femur and tibia are the most common sites. It's one of the lesions that can be in the physis. So when you see a physeal lesion in a child, things other than chondroblastomas should cross your mind, and you may well see more Brody's abscesses than chondroblastomas over a period of time. An example of a Brody's abscess that was referred in to me to evaluate for tumor, showing a lucent lesion in the proximal tibia, nice rim of reactive bone, suggesting a relatively chronic kind of condition. A T1 MRI sequence showing all of the edema, which is relatively low signal on T1 weighted images, and the reactive bone surrounding it with a little abscess cavity within the midst of it. By and large, if it's recognized and treated, it's a relatively benign process. There are a couple of variant osteomyelitises that get asked on the test. Like a lot of things that get asked on the test, their test importance seems to be greater than their real importance. Chronic sclerosing osteomyelitis is disease of the diaphyses, usually the tibia of adolescents. There is dense periosteal new bone formation. It is painful and resistant to treatment. Chronic multifocal osteomyelitis occurs in younger children, tends to be metaphyseal, or it likes the clavicle. And it tends to not be resistant to treatment and will spontaneously resolve. The issues with both of these, more than anything else, are recognition. There are some specialized infections that always get play on the test. Watch out for serratia in IV drug abusers. It tends to be an axial skeleton lesion. Pseudomonas occurs in IV drug abusers and in puncture wounds through tennis shoes. Brucella is a gram-negative that occurs in meat packers and is classic for flat bones, especially the spine. Anaerobes occur from skin infections and from bites. Fungi occur following skin infections and are common in the immunocompromised host. The most common that you will bump into being Candida, particularly in ICU patients. And mycobacteria, remember to check the PPD. They are granulomatous on X-ray, tend to be caseating granulomas as opposed to sarcoidosis, which is a non-caseating granuloma treated with tuberculosis drugs. Infected joint replacement was covered this morning, and I think we will leave it at that. Clenched fist injuries. Assume them to be an injury to the MP joint generally. If you see a clenched fist injury, generally occurs from somebody hitting someone else in the mouth. Should operatively explore it and watch for extensor tendon lacerations and for joint injuries. Tetanus, by and large, is handled in the emergency rooms, who are very much sensitized to it, but something that you should be cognizant of. It is a neuroparalytic disease. It occurs as an effect of an exotoxin from Clostridium tetani. Tends to occur in old, deep, and contaminated wounds. If people have had tetanus prophylaxis within 5 years, they probably don't need to be reprophylaxed. If they don't know or are convinced they haven't had it, then think prophylaxis. Rabies occurs as a virus in animal saliva. It is common in bats, foxes, skunks, raccoons, dogs, and cats. Largely from a clinical perspective, at least in the East, the raccoon is the problem. They are said to be 40 times the population density in the suburbs that they have in the wild. They like neighborhoods, they thrive in neighborhoods, and people come into contact with raccoons. On the other hand, bats are common carriers, but people don't by and large come into contact with bats. Presents as a neuroparalytic disease, again, with central nervous system irritation, paralysis, and death. The treatment involves both vaccine and rabies immune globulin. Hoofed animals don't tend to get it, and rodents don't tend to be carriers of rabies. Foot puncture wounds occur through the sole of tennis shoes, generally a nail. They're common. Staph is the most common bug, but Pseudomonas is the characteristic bug and the bug that usually is sought in terms of questioning. Osteomyelitis will develop in about 1 to 2% of people who get a nail puncture wound through the sole of a tennis shoe. Diabetic foot infections are potentially very severe infections, as you know, leading to a large number of amputations nationwide. Mild infections tend to be gram-positive cocci, like most everything else. Severe infections, though, are polymicrobial, require rapid and aggressive incisions and drainages and debridements, and the antibiotics need to cover multiple organisms. Necrotizing and fasciitis and gas gangrene are potential accompaniments of diabetic foot infections. Paronychia is common. You see them regularly. They come, though, in several varieties, which you should be aware of. The majority will be a staph infection. Dentist and dental hygienist, though, will get herpes, paronychia, and dishwashers whose hands are wet all the time, and this must be sneaking up on a disease of antiquity with all of the mechanical dishwashers now, will get candida and needs to be thought about, and if you have someone with that occupational history, should be looked at with appropriate stains. Fungal infections are infections by multicellular organisms as opposed to single-cell bacteria. They can induce a hypersensitivity reaction. They create a granulomatous infection, but grossly can look like an abscess. Treatment is generally debridement and antifungal agents. Will be covered more under joints. HIV, you are going to get questioned on somehow or another. It is not only common, but it is politically favored. And you are going to get questions on HIV. There's a recent article again in the TAN Journal on HIV. Occurs in homosexual males, particularly IV drug abusers, and huge instance in hemophiliacs associated with a diminished number of CD4 or helper T cells. Diagnosis of AIDS is patient is HIV positive and has an opportunistic infection, or HIV positive and has a CD4 count of less than 200. This is something that in a general practice you're going to bump into. There are people out there. Last time I went to Key West, in fact, when I was checking into my hotel, somebody walked by the desk clerk and asked him how he was doing. He said his CD4 count was up. And it just, there's a lot of HIV positivity out there, as y'all are aware. HIV risk, you know, I don't know what the risk to attending orthopedic surgeons is, but I must get stuck at least once a quarter by a resident with a needle. The incidence is said to be 0.3%. I haven't seen the reference. One of you may have, but one of the last residents that stuck me said that she'd read an article that said it had probably not been reported as a needle stick through gloves, and I hope that's true. It occurs as a risk of blood transfusion. Newest number I've seen actually is higher than that. It's probably closer to 1 in 1.5 million, I think. Similar to the allograft instance with more modern testing. At any rate, the incidence is low, but something y'all are all aware of. There are other entities, though, associated with HIV that haven't, as far as I recall, shown up on in-training yet, but you would think they're bound to be showing up any time with the recent literature in the Journal of American Academy of Orthopedic Surgeons. They get soft tissue infections, pyomyositis, can be tricky because of the AZT myopathy. They can get osteomyelitis, bacillary angiomatosis associated with Bartonella, non-Hodgkin's lymphomas, and Kaposi's sarcomas, y'all are well aware of, I'm sure. And there are a number of inflammatory arthritic conditions associated with HIV and AIDS that I'm not sure is something that will be specifically asking someone to tell the difference between HIV-associated arthritis and acute symmetric polyarthritis, but I would think it would be reasonably fair to ask about joint inflammation. Hepatitis, again, everybody should be aware of, and I haven't spent much effort on this. Hepatitis A is due to poor sanitation and is not generally a surgical problem. B and C, though, clearly are surgical problems. Bear in mind that healthcare workers can be carriers of hepatitis B. Testing is not as effective with hepatitis as it is with HIV at this point. The hepatitis C virus continually changes its genome to some degree, making testing obsolete almost as soon as a test is identified. Antibiotics for open fractures, you may well get asked about. Grade 1 and 2 open fractures, everybody agrees that a first-generation cephalosporin is a good drug. There is some question, especially in 2s, whether the addition of gram-negative coverage with an aminoglycoside is also needed. The answer at the moment, though, I think is first-generation cephalosporin. With grade 3As, clearly an aminoglycoside is indicated. In 3Bs, the mechanism of the injury needs to be thought about. If it is a horribly contaminated wound with soil and the like, then the addition of gram-negative coverage for Clostridia is recommended. And if it is an injury that occurs in water, then consideration of Pseudomonas coverage should be considered. Antibiotic mechanisms of action, again, should be medical school stuff, and I'm going to go through relatively quickly. The common antibiotics that we use a lot, cephalosporins, inhibit cell wall synthesis, as does vancomycin and bacitracin. Beta-lactamase resistance you are aware of with penicillin. Increasing cell wall permeability. If you're in a fungus belt particularly or treating ICU patients, you may well be using amphotericin. Ribosomal inhibition, gentamicin, tobramycin. Tobramycin you're especially going to be using making antibiotic beads. It has good antibiotic elution characteristics. They can bind more than just the 30. They can bind the 50, 70, or 80 S subunits as well and cause a misread of messenger RNA. Ribosomal inhibition drugs are mostly gram-negative drugs. Some drugs affect DNA transcription and translation. Quinolones are derivatives of nalidixic acid. They have a very broad spectrum. There is increasing resistance, unfortunately. Bear in mind the problem in children of tendon ruptures, and you really can't use the Cipro and the other quinolones in children. Rifampin, which you will use some with coag-negative staph, inhibits RNA polymerase. Metronidazole forms oxygen radicals. They're probably not going to be interested in that drug. Again, mechanisms of action we've gone over. Side effects are important. Aminoglycosides, you worry about the ears and the kidneys. Tetracycline stains teeth. It should be used with reservation in children. Not much orthopedic implication. Cephalosporins tend to be relatively non-toxic, which makes them excellent drugs for orthopedic use. And the last thing that we are going to do, and hopefully finish early enough for questions on all of this stuff, is by far the biggest topic that I have to cover. It's on normal and diseased joints. Y'all have, it's chapter 2, I think, in the Miller Review book, and it is a long, involved chapter with a lot of material and a lot of very popular material on the test. The first part of the lecture is going to once again, unfortunately, go to pure basic science. So here I am banging my head on the wall again. The second 2/3 of the lecture is going to be largely clinical, talking about joint diseases, which should, I hope, be more fun. There are several types of joints, syndesmoses, synchondroses, and diarthrodial joints, which you should be aware of. Synchondroses include the intervertebral disc. The cartilage tends to be fibrocartilage, and motion tends to be limited. Diarthrodial joints contain articular cartilage, a capsule, a synovial membrane, are the classic joints that we spend most of our time dealing with. Articular cartilage does have zonation to it, and this is a common concept that they test on. The very uppermost layer has cartilage fibers oriented parallel to the surface of the joint. The chondrocytes are elongated and parallel to each other. There is relatively little proteoglycan and relatively a lot of water in that layer, and its primary function, as you would expect, is shear resistance. The middle zone has collagen fibers of a larger diameter. They're not very well organized. They're not parallel like they are in the upper zone or perpendicular like they are in the next zone. The chondrocytes are rounded. Proteoglycan levels increase, and this primarily serves as resistance to compression. The deep zone has large collagen fibers which are oriented perpendicular to the joint surface. The chondrocytes are columnar. This is the highest level of proteoglycans, and water levels are low, and again this functions primarily in a compression mode. The zone of calcified cartilage is marked by the tide mark, which is an H&E staining phenomenon. It has a cartilage matrix, but there are apatitic salts within it. The cells tend to be small and is felt to have shear properties. Chondrocyte is the functional cell of articular cartilage. It serves to form and maintain the extracellular matrix of the cartilage. It is responsive to growth factors, interleukins, drugs, loads, and pressure changes. There is not a nerve supply, and immunoglobulins are too large to pass into it, so there is a relatively little immune responsiveness. The composition is mostly water, 65 to 80% water, varies with age. Collagen is type 2, bone collagen is type 1. They tend to ask that. Is the next largest component after water. And the major proteoglycan called aggrecan forms 4 to 7% of it, again to some degree age dependent. There are a variety of smaller components which in total make up less than 5% of the articular cartilage. Water has a high concentration superficially and a relatively lower concentration deep. Water content increases with osteoarthritis, another question they ask. The water can be moved by a pressure gradient or by compression. Proteoglycans are hydrophilic and tend to hold water. Collagens, again, they like to ask. Type 1 is your primary collagen in bone. Type 2 is your primary collagen in cartilage. Type 10 is one that they sometimes look for, which is seen in hypertrophic cartilage, and type 9 is involved in the cross-linking of cartilage, is another one they sometimes look for. Collagen gives the articular cartilage its tensile and shear properties. It immobilizes proteoglycans in the extracellular matrix. It is a triple helix and is cross-linked. There is a great deal of glycine, proline, and hydroxyproline in the collagen, which can be measured as breakdown products in people who have cartilage diseases. Again, it is a chained substance formed in a triple helix, has the hole zones that I'm sure Dr. Chabra talked about yesterday, as it also forms the structural unit of bone and serves mineralization functions there. Proteoglycans give the cartilage its compressive strength. There are several common glycosaminoglycan subunits, and this is another one that they like to ask. Chondroitin 4-sulfate is more common in young people. I think this was on last year's in training. It decreases with age. Chondroitin 6-sulfate and keratin sulfate tend to increase with age. The glycosaminoglycan unit's size decreases with aging and decrease with osteoarthritis. The basic structure is the hyaluronate strand. There is a link protein. The glycosaminoglycan subunits are attached to a protein core. And again, this picture, or some semblance of it, tends to show up on a very regular basis. Remember that keratan sulfate decreases with age, chondroitin sulfates increase with age. The molecular organization is that the glycosaminoglycans are intermixed with the collagen, which help to maintain them and to give them structural support. Chondrocyte metabolism is mostly anaerobic. Children have some aerobic chondrocyte metabolism early. They synthesize, assemble, and basically maintain the extracellular matrix, respond to chemical and environmental stimuli. The cartilage is avascular. Its nutrition is primarily diffusion from synovial fluid. You see that clinically with cartilage tumors, which can easily seed a biopsy site because they don't need a blood supply to survive. Diffusion times are relatively lengthy, but the metabolism is relatively low. Interleukins, growth factors, and prostaglandins move freely in the cartilage, but as noted earlier, immunoglobulins don't. The cartilage shouldn't let old people play with computers. Cartilage, the proteoglycans are formed through the standard manner of protein synthesis. The proteins assembled in the rough endoplasmic reticulum go to the Golgi apparatus, where they're put into secretory vesicles and go out into the intracellular matrix, where they are measurable. There they are organized into the subunit shape. They're catabolized. Interleukins are toxic. Immobilization, as you know, is bad for cartilage. The cleavage splits tend to be at the G1 and G2 domains. And again, those fragments, once split, are immeasurable, which may become clinically useful as time goes by. Collagen, remember, is vitamin C dependent for hydroxylation, and that gets asked every once in a while on the various tests. Growth factors are popular. Lot we don't know. We're in the infancy of using them clinically. They regulate cartilage synthesis. There are a lot of different types of growth factors, and they may play a role in primary osteoarthritis. Degradative enzymes are numerous, and that is in part how the cartilage gets broken down. Proteolytic enzymes are formed by the chondrocyte. Common proteolytic enzymes are the metalloproteinases, and the metal that they have in common is zinc, which again is something that is liked. Cartilage ages like the rest of us, unfortunately, does. Young cartilage is more cellular. Mitotic activity decreases or ceases with advancing age. Young cartilage has less collagen and more proteoglycan and more chondroitin 4 sulfate. So this picture's again from the Academy book showing very young cartilage with lots of proteoglycan, lots of mitotic activity, relatively speaking. As one ages, the amount of proteoglycan markedly diminishes, and the activity of the cells, again, markedly diminishes or ceases with age. Cartilage is permeable. It loses fluid with compression. The proteoglycan holds the water, so the more proteoglycan the person has, the less permeable their cartilage is. In osteoarthritis, there's proteoglycan loss and water increase, so it is more permeable. Viscoelasticity is a concept that is almost always looked for. It is a characteristic of articular cartilage in which there is a time-dependent motion. As one applies a constant pressure to the cartilage changes shape. Shear properties, obviously cartilage has to have shear properties. Our joints move and there is shear of one surface on another. In normal cartilage, the amount of friction is virtually none. In pure shear, which may or may not truly exist, there really isn't any volume change in the cartilage. There's intermolecular friction with perhaps a shape change, but in pure shear, there is not truly a volume-dependent deformation. Swelling occurs with loss of proteoglycans, so that again, osteoarthritic cartilage is swollen with a higher water content. Cartilage is aneural, does not have a nerve supply. Monocytes and immunoglobulins are too big to penetrate it. It responds to loading, unloading, and to biochemical and biomechanical changes. Unloading cartilage causes atrophy. Prolonged immobilization is bad for cartilage. The cartilage degenerates. The proteoglycans are lost more rapidly than the collagen. Abnormally increased loads and abnormal motion are also detrimental. You all know that in talking about people with cruciate deficient knees who have abnormal motion and develop arthritic changes as time goes by. And that is, I think, the end of the pure basic science, and now we're going to be back talking about some clinical entities. We're going to talk about arthritises or arthroses. They occur in a variety of types, all of which we should be able to get through over the next hour and a half. Joint fluid analysis is important. You will get asked questions on joint fluid analysis regularly. Almost always it involves infection or gout, but could involve other disease entities. Someone has said that they think that analyzing joint fluid is more important in joints than a urinalysis is in evaluating renal disease. It's especially important in monoarticular arthritis, and in particular, you're looking to be sure that you don't miss an infection. It's said that in a rheumatology practice, evaluation of the joint fluid may change the clinical impression in as many as 20% of patients, and it may give a clue as to a new problem in an established patient. Joint fluid is an ultrafiltrate of plasma. It has a fair amount of hyaluronate in it and smaller amounts of other proteins, including fibrinogen, complement, and various globulins. Joint fluid analysis is something that you will be involved with on a regular basis. Of course, the most common thing that we look at is evaluating for infection. In general, there is an increased amount of joint fluid. Viscosity may not be increased. Ideally, there should be 100,000 or more white cells with 85% polys, although that's not always the case. Sugar measurements probably are not particularly useful. In a normal joint, in the knee, for instance, ideally there's less than 1 millimeter of joint fluid. So that when you're seeing patients in clinic and you aspirate a knee and you get 5, 6, 8 millimeters of normal-looking fluid, that is still a knee that's responding to something. The viscosity is high, meaning it's thick. Classic measurement is to put some between your fingers and see if it sticks to them. Generally not many white blood cells at all in normal joint fluid. The problem becomes when you're dealing with the inflamed patient who is not septic. And there is some overlap between the septic joint and the inflamed, for instance, gouty joint. If you aren't facile at doing it, at least there needs to be somebody around who is facile at looking for crystals, because you often will bump into the clinical problem of an acute gouty flare versus a septic joint in the emergency room. Polarized light is used to look for crystals. Birefringence is the property. Monosodium urate crystals are yellow when the crystal axis is parallel to the compensator. They're also little needle-shaped crystals. This yellow parallel is called negative birefringence. Calcium pyrophosphate disease, the other common inflammatory crystal that you bump into, on the other hand, is blue when the crystal axis is parallel to the compensator. It tends to be short and squatty as opposed to needle-like, and the blueness is positive birefringence. So that here is the typical gouty crystal, and this picture either came from one of the self-assessment exams or from one of the in-training exams. So, this is something that they look for. The CPBD crystal is, as I say, not needle-shaped and tends to be blue or positively birefringent when parallel to the compensator. There are other crystals. The one that you will deal with most commonly, I think, is the steroid crystal, and you may never look at one. I'm not sure I have. But when you give people intra-articular and ligamentous and tendinous and stuff steroid injections, which you're going to do, some of those people will get a steroid flare, and that is a crystal-induced synovitis. The salvation to it is that the crystal's soluble and it's self-limited and goes away, but you're going to get phone calls at night from people that you give cortisone shots to wondering why they hurt like crazy. And then that's from the steroid going in a crystalline manner. The non-inflammatory arthroses include osteoarthritis, neuropathic arthropathies, rheumatic fever, ochronosis, and pulmonary hypertrophic osteoarthropathy. Osteoarthritis, or degenerative joint disease, is the single most common clinical entity in orthopedics. Virtually any adult field you go into is going to be spend a lot of time dealing with osteoarthritis. Y'all are all familiar with it. Progressive loss of articular cartilage. Pathologically, you see an attempt at repair and remodeling, subchondral sclerosis and cyst, and marginal osteophytes. A picture of osteoarthritis showing the worn-off bone with the little buds of granulation tissue trying to heal. The cartilage surface is split and cracked. I don't have a slide of it, but a very commonly asked question that you're going to have to know about is the difference in healing superficial and deep cartilage wounds. The superficial wounds, by and large, don't heal. I don't know how people teach arthroscopy. It must be the hardest thing imaginable to do. But all of those little scuffs that you guys put in 20-year-old athletes' knees with the arthroscope, and your attending is cringing, they stay there presumably forever. Now, they don't lead to degenerative arthritis, but they don't heal. Deep wounds to cartilage create a granulation tissue response. People form a various amount of fibrocartilage, which is inferior mechanically to hyaline cartilage. Subchondral cysts are a coalition of granulation tissue that is made in an attempt by the body to heal the arthritic condition. There is primary and secondary arthritis. Primary, the most common, in which there's not a known inciting incident. Secondary, there is a known injury, infection, or some reason to have it. The incidence obviously goes up with age. There is a defect in the cartilage matrix in primary osteoarthritis involving the type 2 collagen. There are theorized defects in the subchondral bone is another etiology in terms of the shape being different or the subchondral bone being stiffer. And clearly, as you know, people who have even minor degrees of dysplastic hips have a higher instance of development of osteoarthritis. The biochemical alterations are also popularly asked questions. There is a decrease in the proteoglycan content and an increase in the water content. There's an increase in the percentage of chondroitin relative to keratin sulfate. Proteoglycan synthesis actually is increased in osteoarthritis, but less so than the rate of breakdown, thus the progressive loss of articular cartilage. The pathology is fibrillation, cracking, erosions, loss of cartilage. One sees cloning of chondrocytes. There's an increased amount of cell division, which results in some new proteoglycan synthesis, which can be stained for. There is new bone deposition. The subchondral bone is thickened. The surface of the joint gets polished. The name for that is eburnation. Buds of fibrocartilage originate in the subchondral bone. Granulation tissue forms as a healing response. It undergoes myxoid degeneration, leading to the formation of the subchondral or degenerative cyst. Osteophytes are a common accompaniment of osteoarthritis and are not as commonly seen in the inflammatory arthritises. Again, the thickening of the subchondral bone with the complete loss of the cartilage layer, but really not much true inflammatory response. There are changes in the synovium in people with osteoarthritis. There's edema and inflammation. The inflammatory cells tend to be chronic inflammatory cells, which are lymphocytes and plasma cells as opposed to polys. There is thickening and fibrosis of the cartilage. There is a synovitis that is caused by the cartilage coming into the joint. It creates a synovial inflammation, and some of this cartilage can continue to proliferate and survive and form a loose body. Clinically, there is an insidious onset of pain and stiffness. It tends to be worse early. People tend to get better some as the day goes on, at least early into the disease, and gets worse again at night. There is a decreased range of motion and an unpredictable but generally gradual increase in pain as time goes by. X-ray shows a narrowed joint. The narrowing often is asymmetric as opposed to symmetric in the inflammatory arthritises. The loss of cartilage tends to be axial. There is subchondral sclerosis, whereas in the inflammatory arthritises there tends to be osteoporosis. There are marginal osteophytes and subchondral cyst. So that X-rays, classic for arthritis, showing narrowing of the basal joint of the thumb, a very common target joint, osteophytes, and the bone is not osteopenic. Axial narrowing of the joint space as opposed to the central narrowing that's commonly seen in the inflammatory arthritises. And sort of a granddaddy subchondral cyst in a patient with osteoarthritis, showing the irregularity of the joint space, speaking of the spines, and this lytic lesion, which was a geode or subchondral cyst. There are some patterns of distribution in men. It's common in the hips and relatively mild in the spine. Bad knee arthritis is seen in obese hypertensive females, and I don't know how y'all's university is, but boy, at our universities it seems like there's an awful lot of these people getting knee replacements. We look at the young, or not young, but the thin, in-shape female without these huge varus deformities and call them a St. Mary's knee after the local hospital. But this seems to be a very common presentation. It can occur in a generalized form. This is most common in women. It tends to be familial, and there is some HLA antigen concurrence. I've not seen them ask this yet, but in women who get inflammatory arthritis of the hands with these Heberden's nodes or swellings around the distal joints, generalized osteoarthritis can mimic to some degree inflammatory arthritises. And this is an example of someone with generalized osteoarthritis with osteophytes, joint narrowing, the swelling of the joints called Heberden's nodes. Spondylosis deformans is the spinal counterpart of degenerative arthritis. Cervical and lumbar spines are most common, as you know. There's subchondral sclerosis, the disc narrows, there are osteophytes, traction spurs are formed at the anterior longitudinal ligament insertion site, and Schmorl's nodes are common. And examples of common osteoarthritis of the spine. For those of you in general orthopedics and in spines, it will be possibly the most common thing that you bump into on a daily basis. Diffuse idiopathic skeletal hyperostosis is a bony proliferation that occurs at tendon and ligament insertions. It is very common in old men. They often don't hurt much, but complain of a lot of stiffness, especially spinal. It's associated with obesity and adult-onset diabetes mellitus. The tendon and ligament insertion site, bony overgrowth, and the spines can become very stiff, generally not a surgical entity. Neuropathic joints is something that gets asked all the time and is something that you should expect to bump into. There's joint destruction with marked fragmentation of the bone or massive osteophytes. Classically associated with tabes dorsalis. We don't see much now, but now very commonly associated with diabetes, especially in the foot. In the upper extremity, think about syringomyelia or leprosy or Hansen's disease, also associated with alcoholics. The x-rays of the foot show this marked deformity and osteophyte formation. X-ray of the knee showing the gross destruction, much more than you expect from normal arthritic knee, should lead you to at least think about it. This is a patient that I've treated in the last 2 weeks who presented with marked destruction of his shoulder. If you look closely, there's some bone changes down here. Another surgeon thought he was infected, debrided him, sent the pathology, was read as osteosarcoma both at the local hospital and at a world-famous referral center. I looked at the x-rays and just didn't like it for osteosarcoma. Told my pathologist I just didn't like it for that, sent it off to Dr. Dorfman in New York, who's sort of currently the guru, and he agreed with me that this looks like a Charcot joint. MRI'd his neck. He had kind of a funny looking hand, and he's got a syrinx. Was read as osteosarcoma, I say, at one of the best 2 or 3 known places in the world. A frightening thing. But when things don't fit, you need to recognize and think about things not fitting. I did my fellowship with Dr. Enneking, and he used to laugh at orthopedists, said that if you get an x-ray, you go look at it. And if you don't like the way the radiologist read the x-ray, you go beat them over the head and tell them you don't like it. But if you get a path report, you guys think it's etched in stone. And it is every bit as much of an art as looking at an x-ray is, and so when things don't fit, question them. Neuropathic joint etiology, it has a couple of different presumptive etiologies: loss of the protective function of pain, or a neural-mediated vascular reflex, and these are not mutually exclusive. Acute rheumatic fever, you know, they've asked about this on in training, and I'm not sure. I think it's important enough in an orthopedic perspective to do that, but they do ask about it, so we need to at least mention it. Used to be common, and people my age who watched cardiac surgery grow up used to see 4, 5, 6 valves a week being done by a cardiac surgeon. Now you see a valve on the schedule and you kind of go, wow. And most of that was from people who'd had rheumatic fever. It used to be a big, big, big entity. It's due to an untreated strep infection. Carditis was the worst of the clinical manifestations. It presented with a skin rash and with subcutaneous nodules and a migratory large joint arthritis. The ASO level is elevated in about 80% of people. There are Jones criteria, and that's what I've seen asked recently, which requires a strep infection with either 2 major or 1 major and 2 minor criteria. And the criteria you should at least recognize, even if you don't remember the formula. And the major are carditis, polyarthritis, chorea or funny movements, erythema marginatum, and subacute nodules. The minor criteria are fever, arthralgia, a history of rheumatic fever, an elevated SED rate, and a prolonged PR interval on electrocardiography. Ochronosis seems to show up on in-training about every 4 years, also called alkaptonuria. It is a defect in homogentistic acid metabolism. Excessive homogentistic acid gets deposited in the joint. The cartilage turns black. It degenerates early, commonly associated with back pain and disc space narrowing. Y'all won't, but I always remember this because in Dr. Inneking's course, his picture of ochronosis was in a guy that was electrocuted in the Florida electric chair, and we always wondered how he knew that was ochronosis and not something else. But it shows up. There is this staining in the synovial fluid if you happen to draw it and look at it, and if you see it arthroscopically, the cartilage is black. Hypertrophic osteoarthropathy shows up regularly on in-trainings. Almost always the secondary osteoarthropathy is what they're interested in. It's associated with clubbing of digits, periosteal new bone formation, painful swollen joints, and chronic lung diseases. The classic lung disease is bronchogenic carcinoma, and that's the one they tend to ask about. But it can occur in a bunch of other lung diseases, and this is a test question that they like. There is a primary hypertrophic osteoarthropathy that is showing up in all the books now, so it's bound to show up on the test soon. It's much less common, occurs in adolescent black men. They have enlarged hands and feet because of this dactylitis or periosteal new bone formation, and it is not associated with lung diseases. The secondary form occurs in 5 to 10% of people with lung cancers. Clubbing of the fingers and toes, but you generally get asked to see them because they hurt. And if you're in an institution like mine, you can't get a rheumatologist to see somebody, but you can get orthopedics to come by. So you get consulted on people who have this on occasion. The bones have periosteal new bone formation, and if it's possible to eliminate the underlying problem, the new bone formation tends not be progressive. And this is for me. I've been talking so long I think my throat is getting a blister. Inflammatory arthritises. Again, this is something you're going to see on the test. There's going to be one or more questions on every test you ever take on the inflammatory arthritises. They include a number of things that are important to orthopedists. Rheumatoid arthritis, juvenile rheumatoid arthritis, the spondyloarthropathies, and gout especially. But I get referred an old guy with polymyalgia rheumatica virtually every year. It's not a dime a dozen, but I don't have a general orthopedic practice, so somebody who is out in the world in a general orthopedic practice is going to see even more of that. Rheumatoid arthritis is the most common inflammatory arthritis, the classic inflammatory arthritis. It occurs in 1% of white people. Women are twice as likely to get it as men. There is a genetic predisposition with a human lymphocyte antigen abnormality that is common, and it has 9 times the expected incidence in identical twins, so there is some genetic predisposition to rheumatoid arthritis. Occurs in relatively young people. They present with generalized fatigue, weakness, and joint pain. These people feel sick. The larger joints of the hand and fingers are usually the first affected joint, so that the MPs and PIPs are where it's generally picked up first. Every joint can get involved with it as time goes by. The rheumatoid factor is the most helpful diagnostic test present in 80% of people with rheumatoid arthritis. This is a test question constantly. It is an IgM immunoglobulin. It is an autoantibody directed against the Fc fragment of IgG. It is present in other paths that we're going to look at, and some normal people have rheumatoid factors. So it is not absolutely diagnostic, but is certainly suggestive. It is also seen in Sjogren's syndrome and sarcoidosis and lupus. I don't know that we come back to this, so we'll do it now. HLA-27 is seen in the seronegative spondyloarthropathies, and you will get asked that regularly. And ANA is seen in systemic lupus, Sjogren's, and scleroderma, with systemic lupus being the disease of major orthopedic import. The etiology of rheumatoid arthritis is not known. It's possibly infectious. It clearly involves a T-cell mediated immune response with antibodies directed against normal tissues. The synovial changes include edematous frons, hyperplasia of the synovium, CD4 positive T lymphocytes are common. Also, plasma cells, macrophages, and the cytotoxic T cells are seen. Fibrinoid necrosis of these synovial frons leads to the deposition in the joints of little white bodies that look like rice nodules called rice bodies. The articular cartilage changes are secondary to the synovial inflammation as opposed to being primary changes as seen in osteoarthritis. Granulation tissue covers the cartilage. Various cytokines and collagenases are elaborated. The cartilage gets destroyed. As the cartilage is completely destroyed, the disease tends to burn out, leaving a stiff fibrotic joint. Subchondral bone changes include inflammatory cells in the subchondral bone. These often are contiguous with the synovium. Of particular importance and something that shows up regularly is diffuse osteopenia, so that one of the hallmarks of a rheumatoid x-ray is the periarticular osteopenia, which you don't tend to see in the non-inflammatory arthritises. The pathology is inflammation. There's hypertrophy of the synovial villi, lymphoid aggregates, and enlarged vessels that can be seen. The cell type is inflammatory as opposed to neoplastic. Most are chronic inflammatory cells, as I noted earlier, lymphocytes and plasma cells, as opposed to the acute inflammatory cells that you would expect to see in gout or septic arthritis. There is a little entity that was asked once upon a time on one of the tests called a Russell body, which is an immunoglobulin-rich plasma cell cytoplasm that is characteristic for rheumatoid arthritis. As time goes by, pannus covers the joint and the cartilage is destroyed. The subchondral bone gets invaded with granulation tissue and leads to destruction of the bone. X-ray is joint narrowing with marginal erosions as opposed to the subchondral cyst of degenerative arthritis, which are not generally marginal. The joint narrowing tends to be diffuse rather than focal, so that the varus deformity seen in DJD is not commonly seen or wouldn't be expected with rheumatoid arthritis. And there is the periarticular osteopenia, which is an X-ray characteristic. Erosive arthritis is commonly seen here at the joint margin with the periarticular osteopenia. The spine is commonly asked in rheumatoid arthritis. I assume that Dr. Lauerman covered that in the spine lectures. C1-2 instability and subaxial instabilities are the processes that will be looked for. Systemic lupus occurs primarily in black women. It is an inflammatory arthritis of unknown etiology. It's not as destructive as rheumatoid arthritis. The primary mortality in systemic lupus is renal. It is associated with a positive ANA test or antinuclear antibody, and sometimes has a positive rheumatoid factor. Joint involvement is common. Patients like rheumatoid patients are systemically ill with a fever, butterfly rash on the face, pericarditis, nephritis. Both entities are primarily treated medically. Don't know how well the butterfly rash scanned into the computer, but that is common with systemic lupus, as are these inflammatory joint changes. Polymyalgia rheumatica is common in older people. It presents as proximal muscle weakness and stiffness, so that people feel weak around the shoulders and hips. They also tend to feel generally ill. Headaches are a common accompaniment. Temporal arteritis is commonly associated with it and is often a means of making the diagnosis to actually biopsy the temporal artery. It's associated with an elevated sedimentation rate and alkaline phosphatase. The muscles can become very inflamed on MRI scanning and suggest infections and even at times tumors. Juvenile rheumatoid arthritis is asked on in training essentially every year. It's the most common rheumatologic disorder of children. Most are seronegative as opposed to adults who are 80% seropositive. 90% of children with juvenile rheumatoid arthritis are not seropositive. There are more systemic manifestations with JRA than are common with rheumatoid arthritis. Many children with JRA recover completely, but many don't. There are a variety of forms. The posse articular is the most common. It occurs 55 to 75% of the time. It involves 4 or fewer joints. If it involves 5 joints, it doesn't qualify for posse articular. It is common in young children. The knee is the most common joint. and it's associated with eye problems, which has been asked on one of the tests not in the not too distant past. Polyarticular JRA is about 20% of the cases. These are the ones who are most likely to have a positive rheumatoid factor. Involves 5 or more joints. It also is associated with systemic findings. Prognosis for polyarticular is better than for polyarticular in terms of long-term joint destruction. Systemic onset JRA is about the same commonness as polyarticular. It's the most serious form. Involves a variety of organs, including the liver, spleen, heart, and lung. About 50% of these people will develop progressive arthritic changes as time goes by. X-ray of JRA is reminiscent in some ways of adults. There is periarticular osteoporosis. There is relatively symmetric joint space narrowing. It is associated with some constriction of the bony diaphyses and is associated with epiphyseal enlargement or ballooning. The other X-ray presentation, again, the periarticular osteoporosis, common in both the adult and children's forms, sometimes a growth recovery line, and metaphyseal sclerosis, with what often looks like some widening of the epiphysis seen in children with JRA. The spine involvement in JRA is common. It's a little bit different than the spine involvement in adult arthritis. They tend to become ankylosed with long, thin vertebrae, the classic X-ray picture of the JRA spine. Seronegative spondyloarthropathies are uncommon but not rare. General orthopedists and spine surgeons are going to see these people. They tend to occur in relatively younger people. There are a variety of them, including ankylosing spondylitis, Reiter syndrome, psoriatic arthritis, and arthritis associated with inflammatory bowel disease. They tend to be variably HLA-B27 positive and rheumatoid factor negative. Ankylosing spondylitis is the most common one. Possible association with a couple of organisms, Klebsiella and Yersinia. 2/3 of people have spinal involvement only. Enthesopathies or inflammations at tendon and ligament insertions are commonly associated with the seronegative spondyloarthropathies. They sometimes get exuberant reactive bone formation or even an erosion at ligament insertions. Bony osteophytes bridge the vertebral body at a location that is even with the body as opposed to osteoarthritis where the osteophytes protrude. Flexion deformities are common. Stiffness is common. They're associated with very difficult cervical spine fractures with, that are hard to treat and have high morbidities. The peripheral joint pathology is inflammatory, similar to rheumatoid arthritis, associated with protrusio in the hips, and there are a variety of systemic manifestations. Most are males. Average age is young. 90% are HLA-27 positive, and the SED rate is elevated in a large majority. The sacroiliac joint is usually involved, and I make a plea with my residents when they are seeing patients and getting spine x-rays to try to look at everything but the spine first. If you focus right in on the spine, you overlook other things like blinking owl signs with metastatic disease, kidney stones, and sacroiliac joint involvement that you see with the seronegative spondyloarthropathies. The course is variable. Most people do okay. They're stiff, they're sore, but are functional. Some people get very, very stiff and are significantly disabled. You all have seen the pictures in the textbooks of people who are bent forward with their chin almost on their knees. Osteotomies often required to correct the deformities. Again, the bamboo spine in ankylosing spondylitis, in the sacroiliac joint erosions, in my role as tumor surgeon. The other thing is this is an area where you see tumors. Chondrosarcomas I've seen there on several occasions, and so when you order a spine film, look at areas other than the spine. Reiter syndrome, conjunctivitis, uveitis, and arthritis. There's some eponym that I can't remember. They can't see, they can't pee, and they can't do something associated with the arthritis that helps to remember it. Climb a tree. There you go. Can't see, can't pee, can't climb a tree. There you go. Which I think is helpful to remember some of this stuff. It's associated with a skin lesion. Generally, when they ask us about it on examinations, it's associated with heel pain, but they generally give some of this other history. The arthritis is abrupt and inflammatory. HLA-27 largely positive, but less so than in ankylosing spondylitis. Again, the sacroiliac joint is a commonly involved joint. And here is a picture of someone with massive new bone formation around tendon and ligament insertions with Reiter syndrome. This is a picture of the keratoderma blennoragicum, the skin lesion that is seen. I've never seen them ask you guys to identify that, but looking at the picture kind of sometimes helps you remember it. Psoriasis is relatively common, 1 to 2% of the population. 5% of those people develop arthritis. Only 50% of people with psoriatic arthritis are HLA-B27 positive. So we've diminished from 90% in ankylosing spondylitis to 80 in Reiter's to 50 in psoriatic. You're going to see and treat some people with psoriatic arthritis, and I'm sure most of you guys in joint and women in joint replacement centers have seen people with bad psoriasis right where you want to make an incision, usually more for a knee than a hip replacement, but these plaques are common in the back near a posterior hip incision, and they are a pain because they are associated with a much higher rate of developing infection in the joint if you can't get the skin lesion under control. They are commonly associated with hand involvement, with sausage-shaped digits. The hand lesions can be severe, and about a quarter of people with psoriatic arthritis have involvement of the sacroiliac joint. Picture of a person with the sausage digit destruction. The distal joint is classic for psoriatic arthritis as opposed to rheumatoid, preferring the MPs and PIPs, and erosions of the calcaneus at the area of plantar fascia, an erosive bone destruction as opposed to the Reiters that we looked at, which could also have been erosive, showing the bone formation. Neuropathic arthritis occurs in 10 to 20% of people with Crohn's and ulcerative colitis. Tends to be non-deforming and consequently not a surgical issue. Tends to be large joints. Familiarity so that you recognize it is important because you may be asked to see people with painful swollen joints, and in your history find out they have Crohn's disease, and you may be more likely to recognize that than the standard family practitioner is. 50% HLA-B27 positive. Gout. Those of you who do adult in general orthopedics are going to see gout. It's relatively common. People show up hurting like crazy in your office or in the emergency room. They get an inflammatory arthritis due to tissue deposition of monosodium urate crystals. Uric acid is the final breakdown product of purine bases. They often will have hyperuricemia, chronic renal failure, various gallbladder and kidney stones. Most of the people who are hyperuricemic have some decreased renal clearance. People show up with sudden pain, swelling, and redness. Looks infected very commonly. Podagra, or the MP joint of the big toe, is the classic location, but certainly not the only location. A lot of people with an acute inflammatory arthritis from gout have a history and makes the diagnosis easier, but they don't all, and some of the people you see may have a history but not be intelligent enough to be able to help you with that. Tophi, or collections of urate crystals, generally occur as late sequelae and generally are not a diagnostic difficulty. Gouty X-ray early shows soft tissue swelling. You may have periarticular soft tissue densities. Bone erosions tend to be periarticular with a sclerotic rim. Gouty arthritis tends to lack the periarticular osteoporosis. Joint space tends to be preserved, helping to differentiate it radiographically from rheumatoid arthritis. Classic gouty X-ray of podagra with marginal erosion. Here another erosion with a sclerotic rim of bone, which you might well not see in a rheumatoid erosion. Again, negative birefringence, long needle-shaped crystals. And again, this picture is taken from one of the self-assessment exams and is something that you should expect to bump into very likely. Treatment is acute and chronic. The acute treatment is, if people can tolerate it, a non-steroidal anti-inflammatory drug, of which indomethacin seems to work particularly well. It inhibits phagocytosis of these gouty crystals. Colchicine inhibits inflammatory mediators. They both have gastrointestinal problems. As you know, indocin can give you heartburn and ulcers. Colchicine can make people deathly nauseated. Allopurinol is the chronic treatment. It is a xanthine oxidase inhibitor. If given acutely, it may potentiate the acute attack, but on a long-term basis in people who maintain elevated levels of uric acid is the mainstay of treatment. Diet modifications also are used. Chondrocalcinosis, or calcium pyrophosphate deposition disease, is common in old people. It tends to involve an older population than gout does. Calcium pyrophosphate crystals form adjacent to the chondrocyte. They're shed into the joint and seed other tissues. 6% of people over 70 will have radiographic evidence of chondrocalcinosis. Many people are asymptomatic. Pseudo-gout, as it is sometimes called, is the most common acute arthritis in older people. Chronic pyrophosphate arthropathy mimics osteoarthritis. One can get tophaceous pseudo-gout where the crystals form periarticular soft tissue masses, but again, they're calcium pyrophosphate, not monosodium urate crystals. The X-ray is chondrocalcinosis, joint space narrowing, and subchondral sclerosis, so that the classic X-ray that you've all seen is calcification within the menisci and the knee, or within commonly the triangular fibrocartilage of the wrist. The crystals we looked at earlier are positively birefringent and different shaped than gout crystals. It's also associated with an entity called the Milwaukee shoulder, which is a relatively acute destructive arthritis of the shoulder that is sometimes associated, and the X-ray is terrible, but sometimes associated with calcium pyrophosphate crystals visible on X-ray. Infectious arthritis is critical to recognize and be aware of. If you miss calcium pyrophosphate disease for a week or two or a month, it doesn't make much difference. If you miss a pyogenic arthritis, clearly that will lead to joint destruction. A variety of infectious arthritises exist, all of which will be touched on. Pyogenic arthritis occur as a result of hematogenous spread, contiguous osteomyelitis, remember the hip in children, and puncture wounds. It is less common than osteomyelitis, but is rapidly destructive to articular cartilage. It is possible to see chondrocyte death within 48 hours of initiation of pyogenic arthritis. May progress even in the absence of apparently viable bacteria. Remember the glycocalyx again. It doesn't necessarily require a metallic surface, and occasionally extensive synovectomies will be done on patients who have recalcitrant pyogenic arthritis. Presents as an acute, painful, swollen joint. White blood cells usually significantly greater than 50,000. If less than that, you really wonder about the diagnosis. 80% polys, culture and sensitivity in pyogenic arthritis, much more likely to be positive than in a septic replaced joint. Glucose and LDH are not distinctive. As many as 10 to 20% can be polyarticular. There are predispositions. Rheumatoid patients are more likely to get it. IV drug abusers, remember the sacroiliac and sternoclavicular joints. That's a commonly asked questions. Prosthetic joints get infected both acutely and late. The late infection's a heartbreaking thing. People with systemic illnesses are predisposed to it. Children and elderly patients, for some reason, have a predisposition to the shoulder, which often is initially overlooked. Staph aureus is the most common bug. Often see methicillin-resistant staph with IV drug abusers. Any organism basically can do it. Think about Pasteurella in cats and dogs. Haemophilus, not so much with immunization anymore, but in young children. And brucellosis, particularly in farmers and meat packers. Sacroiliac joint and spine are common joints for brucellosis, and that got asked on in training in the not too distant past. The X-ray changes is a symmetric arthritis with destruction of the bone. You'd like to pick it up before then. Treatment is incision and drainage, possibly a synovectomy in recalcitrant disease, and appropriate antibiotics. Accessible joints can be washed out and debrided arthroscopically. Accessible joints like the knee even can be treated with multiple aspirations and antibiotics. And as an orthopedist, I know I'm prejudiced, but you know, it sometimes hurts to go to a medicine floor and see somebody that has 30 needle sticks in their knee where they've been aspirating it every day for 2 weeks because they want to save them an operation. You wonder which the more aggressive treatment is. Gonococcal arthritis is something that you're likely to bump into if you're doing emergency room coverage. This is a common source of polyarticular arthritis associated with tenosynovial inflammation and dermatitis. Obviously, you think about it in young, sexually active people. Culture and sensitivity is positive. in a variable number of people, some of which is due to the fact that it's hard to culture. And you have to remember to get the appropriate culture media if you're going to aspirate a joint and try to grow gonococcus, or have ready access to your lab where you can get to the lab tech and be sure that they appropriately plate it. Obviously commonly cultured from the genitourinary tract. Generally treated with drugs, and the response is generally dramatic, and if you don't get a dramatic response, you question your diagnosis. Tuberculous arthritis is a commonly asked question. There's been some resurgence of tuberculosis in recent years associated with the immunocompromised population. Occurs in joints from hematogenous spread, in the spine called Pott's disease, most commonly monoarticular, and in peripheral joints most common in the lower extremities. It is increasing with immigration in the country, associated with immunocompromised and malnourished people. The diagnosis can be difficult. One, you don't tend to think about it. The infection is relatively indolent. Constitutional symptoms may be very subtle. And skin test, even if you do think about it, may not be absolutely accurate. X-rays are not necessarily characteristic. Spondylitis is a common manifestation, but it also presents as osteomyelitis, septic arthritis, and abscesses. In an inner city population like I serve, we drain a tuberculous abscess every few months. If you are out in a middle-class hospital, you're not likely to bump into as much of it. It's treated with multiple drugs. I don't believe that they will ask specifics about the drugs, but there are reasons for the usage of the multiple drugs. The disease is having a tendency to become more virulent, with multi-drug resistance increasing. Other mycobacteria occur. The one that they seem to like the best is Mycobacterium marinum, which I talked about earlier under infections. Occurs in marine environments. If you're in the middle of America, you're not as likely to see this. Mycobacterium avium associated with HIV, and Mycobacterium leprae or leprosy. Remember, a common cause of neuropathic joints in the upper extremity is usually the way that it is looked for. Tuberculosis ideally has a positive PPD. They don't all. When you operate on someone with an abscess, you need to be sure that you get all of the information that you want to get. And you get a lot more information when you ask for it than you get when you expect it. So that if you suspect tuberculosis and you're sending gram stains and stuff, you really need to bother to make the phone call to your lab tech who's doing this and ask them to think about it. Because like you, they don't think about it very often. The organisms are fairly small and relatively easy to overlook, and you will get more information out if you put more information in. Cultures take weeks and weeks to grow, and ideally you'd like to make the diagnosis before the culture takes place. It's a granulomatous infection under the microscope. There is necrosis or caseation, which is commonly seen. X-ray is not diagnostic. There is bone destruction, joint space narrowing. It occurs in the anterior aspect of the spine, can present as abscesses. There is nothing diagnostic about these particular X-rays, but they show a destructive arthritis that you certainly would consider as a septic arthritis, and in an appropriate population, TB should cross your mind. Again, there are granulomas, there are Langerhans giant cells. These are giant cells with multiple nuclei that are peripheral, as opposed to the osteoclast-like giant cell that you commonly see in tumors, which has multiple central nuclei. This is different than the Langerhans cell histiocytosis. There is no ER in this. Treatment of tuberculosis is surgical debridement and antibiotics. Fungal arthritis is relatively rare. There are some areas of the country, for those of you who are in them, you know, that are in various fungal belts. It's usually diagnosed by pathology or culture. If you're in a fungal belt, your pathologist will probably be smart enough to stain for the organisms. But if you're not and you're seeing funny looking granulomas, you need to ask them to do that. Common in immunocompromised people. Arthritis is less common than fungal osteomyelitis. What you usually will see in clinical practice is candidiasis in the very sick, immunocompromised hospital patient, but the fungal arthritises occur in neonates, HIV-positive people, and drug abusers. Coccidioidomycosis is common in the southwestern United States. People from Arizona and the like, I'm sure, have seen that. We would be shocked to bump into one of those in Virginia. Blastomycosis, common in central and south central United States. These people often are ill, and joint and bone involvement is much less common than the constitutional involvement. Sporotrichosis is seldom seen, but commonly enters a differential diagnosis consideration. I have a funny practice in that I see a lot of lumps, but I see a lot of upper extremity lumps, and among the things that you think about are lymphadenopathy from cat scratch disease or sporotrichosis, commonly called drunken rose gardener disease, and seen in people who work agriculturally or do a lot of gardening. Candida is the common bug. It is relatively common in big hospitals with sick patients associated with immunocompromised host and central lines. It is not a granulomatous disease like the other fungal diseases are, but it is stainable, and in the right person should be something that crosses your mind. Lyme disease, they like. It's associated with the deer tick as opposed to the dog tick. Northeast United States is the most common location. Commonly missed, presents with a variety of clinical symptoms, including a rash, Bell's palsy, and cardiac symptoms. Associated with an inflammatory arthritis, which is not generally an early manifestation. You can test for it, improve the diagnosis, and it is treated with antibiotics. Hemorrhagic effusions is the last thing we're going to look at today. Thank heavens for all of us. Associated with hemophilia, sickle cell disease, and pigmented villonodular synovitis. Hemophilia you probably will see a lot of or almost none of. If you do sports medicine and joint replacements, you and develop a friendship with pediatric hematologist, you may see a lot more hemophilia than you want to see. If you don't do that, you will hardly see it. Generally, the patients know they have it before they present with an effusion. Sickle cell disease and pigmented villonodular synovitis we'll also look at. Hemophilia is an X-linked recessive disorder generally a factor VIII deficiency with a variant hemophilia B being a factor IX deficiency or Christmas disease. Presents with hemarthroses, synovitis, and joint destruction. Can also present with subperiosteal bleeds and very, very funny looking bones. One of the funniest things I ever watched was Dr. Enneking at his course presented a hemophiliac pseudotumor to somebody, and he taught the way I prefer to, which is firing questions and getting answers as opposed to lecturing. And this guy went down the primrose path, thought it was a osteosarcoma, amputated the leg in conference. Dr. Enneking then told him it was hemophiliac pseudotumor and says, now what? And the guy says, well, I'm going to sew it back on. And Dr. Enneking is a tough man to poke fun at, you know, big, tall, athletic guy, and he just howled at that. So remember the hemophiliac pseudotumor. The severity of the disease is related to the degree of factor deficiency. Knee is the most commonly involved joint, but the ankle is not at all uncommon. Presents with swelling, pain, and decreased range of motion. Hemophiliacs can get bleeds into their psoas muscle and present with femoral nerve palsies is something else to keep in mind. And it hasn't been recently, but sometime over the last 10 years or so that showed up on an in-training. The joint is symmetrically destroyed. Generally, it is not a diagnostic problem. You are unlikely, as an orthopedist, to diagnose hemophilia in the emergency room, but you may well be asked to involve treating it. Treatments involve synovectomies, radiation synovectomies, and joint replacements. Remember that virtually everybody you do a joint replacement on is going to be HIV positive, and think about protecting yourself and your staff even if you don't think they are. The question that gets asked commonly is factor levels. You should have 100% of the factor level the first week and 50 to 75% the second week. Very sadly, up to 90% of these kids are HIV positive. A number of people have an inhibitor, and that may inhibit you from being able to do surgery on them. If you can't control their bleeding, you can't operate on them. Sickle cell disease, 1% of African Americans associated with bone infarcts and periosteal new bone formation, particularly in the hands. Common question is osteomyelitis. Salmonella is the characteristic organism. Staphylococcus is the common organism. This is the dactylitis of sickle cell disease with the periosteal new bone formation, swollen, painful digits in young black kids. Pigmented villonodular synovitis is an exuberant proliferation of the synovium of unknown etiology. There are hemosiderin deposits within the synovium, presents as pain, swelling, synovitis, and a bloody effusion. Knee is the most common joint involved, but it involves virtually any joint at some point, one time or another. I've done toe joints, finger joints, so that it can be anywhere. You can create a synovitis in the knee by injecting blood, but the pathology will not be the same as pigmented villonodular synovitis. There are juxtacortical erosions, sclerotic margins to the erosions. It's a slow-going process. The pathology shows pigmented synovial histiocytes, foam cells, and giant cells. Treatment is synovectomy. Radiation synovectomy is used but not clearly proven. Joint replacement in completely destroyed joints. The cartilage seems to have something to do with this. Once the cartilage is all destroyed, the process tends to burn out. Classic X-ray of PVNS with erosions on both sides of the joint. Sclerotic rim showing that it is a relatively chronic process. Comes in a couple of extremity forms. This is a nodular form of pigmented villonodular synovitis. It was not diffuse. The rest of the synovium in that knee looked reasonably good. And here is the diffuse form of pigmented villonodular synovitis, showing that the synovium is diffusely involved. Arthroscopically, you see this discolored hypertrophic synovium, often with some arthritic type bone destruction. Arthroscopic synovectomy is certainly a reasonable thing to do. Repeated arthroscopic synovectomies are clearly less morbid than repeated open synovectomies. If you don't feel like you're doing a good job with the arthroscope, then around the knee they require a multiple incision synovectomy. A recent report in Journal of Bone and Joint Surgery described 4 incision synovectomies with a relatively low recurrence rate. Classically, we've done 2 incision synovectomies. Some joints just are not amenable to sticking an arthroscope into. The pathology is this villous synovial proliferation with hemosiderin, very thickened synovium. And so good luck. I hope you guys do well on the test, and I hope this has been helpful. Thank you very much. Any questions? We've got about 20 minutes.